Hi, good evening. Dr. Matthew Gordon. Thank you for joining us all tonight. I'm going to give a talk on knee pain. I'm going to talk about, obviously, prevention. It's better off to not get knee pain and then treatment if necessary. So jump right in. Just quickly about me, I went to medical school at SUNY Upstate in Syracuse, New York. I did a residency in orthopedic surgery at SUNY Downstate, which is in Brooklyn, New York, and then did a orthopedic fellowship in sports medicine in Cincinnati, Ohio. Been in practice now for approximately 11 years at Crystal Run over here in Newburgh for about 6 years, and I'm also affiliated with Montefiore St. Luke's Hospital. Sorry. Just quickly, some legal stuff. Obviously, the purpose of this presentation is to give information. It's not meant as a tool to help you diagnose, treat, or prevent any medical conditions. I'm going to give a broad overview of common knee conditions, but any specific questions should be directed to a doctor. So overview, we're going to talk about the knee, some basic anatomy, some basic function of the knee, what makes it work and how it works, some prevention of knee pain in those areas, exercise, nutrition, and avoiding injury. Then we're going to talk about some common knee problems as well as the treatment options available for them. And then, as I said before, we're going to do questions at the end if there are any. So the knee joint, as we're all familiar, it's basically a hinge joint. It bends front to back. It's composed of 3 bones: the thigh bone, which is the femur up on top there. Or excuse me, actually 4 bones: the tibia, which is the shin bone, the patella, which is the kneecap, which is kind of in the center of the picture there. And then there's the fibula, which is a small bone on the outside of the leg. It's not in the knee specifically, but there is one of the ligament attachments onto that area, so it's notable for that. On the ends of the bones, there is what's called cartilage. It is the joint linings of the bone, and it provides a cushion to it. And it also produces a fluid, which when it gets between the layers of cartilage, makes it 10 times more slippery than ice skate on ice. So it makes it an almost friction-free joint when healthy. However, when it's unhealthy, that disappears. There's also what are called the medial and lateral meniscus, or menisci for plural. Those are the cushions that sit between the bones, and you can see the picture there. Others are kind of right in the center of the knee on either side, and those provide additional cushion in the knee. You also have ligaments within the knee, which help stabilize the knee. In the center of the knee, you have what's called the ACL, or anterior cruciate ligament. You have the PCL, or posterior cruciate ligament, which is behind that. And then on the inside of the knee, you have the MCL, or medial collateral ligament. On the outer part of the knee, you have the LCL, or lateral collateral ligament. A little bit more, just go to the next layer of things here. So the tendons and the muscles, the primary muscle in the front of the knee is the quadriceps muscle. It helps to straighten the leg. And then the quadriceps tendon, which is what attaches to that, and the patellar tendon, which attaches the kneecap or the patella down to the shin bone. And then the hamstrings are the muscles and then tendons in the back of the knee. Those are the ones that bend the knee. And then the iliotibial bend, which is a long tendon that runs actually from the top of the pelvis to just below the knee. So in terms of prevention of knee injuries, the key thing really is to reduce the impact on knees. Knees are very sensitive. I like to say, at your kneecap in particular, they can bear 7 to 8 times your body weight. It's important to have good weight control to keep your weight in as optimal level as possible. And then obviously proper nutrition associated with that, eating well, can help you to maintain your weight. Routine exercise is important. You want to keep your muscles strong. The motion of the knee, particularly with the cartilage, helps keep it healthy. We'll talk a little bit more about that going forward. And then frankly, rest periods. It's very important to do an activity and then give your body time to recover. High impact activities, if possible, should be avoided, particularly as you get up there in age, because you don't want to get to the point where you're able or we're prevented from getting to exercise. I always say the exercise you're doing is better than the exercise you're not doing. So if you can find an exercise regimen that's sustainable, that you can do without getting an injury to your knee or frankly any other part of your body, that's the one you want to go with. And then that varies by the individual. So obviously pick an exercise that's good for you. So nutrition and health, we all know the saying, you are what you eat. So if you want to be healthy, you have to eat healthy. You can consult with your primary doctor if there are any specific questions about that, and they might refer you out to a nutritionist. If you are healthy and you eat healthy, you can't avoid every problem. However, when they occur, you can deal with them better. So it helps you to cope better, it helps you to recover better. And then part of that is actually our thoughts. So if you want to think healthy, you want to form healthy habits. And then frankly, I know I put it there, is happiness. Happiness has a positive impact on health. If you want to be healthy, if you feel good about yourself, if you feel good in general, you will generally have better health. And finally, specific to bone health, you want to maintain strong bones. That includes taking things like vitamin D, calcium, vitamin C, as well as proper protein levels. So let's go into some specific knee issues now. So what category of pain, which we call kneecap disorders. These are the most common knee issue. And the reason for this is that the kneecap in particular is vulnerable. The kind of symptoms that you're going to see with this are pain in front of the knee, in the front part of the knee. It's usually worse in stairs. It's worse with kneeling or squatting. And it's also worse if you sit for a long time and then go to get up, which is called startup pain. Most of these occur, or at least in the initial stage, just because the kneecap is not moving properly. The kneecap is a particular type of bone that's contained all within tendons. It doesn't have any strong ligament attachments to it, so it can move around. It's a floating bone in essence. And if it is not controlled by the muscles up above or by the ligaments on either side that help it track correctly, it can cause excess pressure on the cartilage on the linings of the joint, which causes pain. Initial treatment for this makes sense. Rest it. If it's hurting, don't do it. Ice your knee as well. That will help reduce inflammation. And then anti-inflammatories, so long as you're able to take them, something like Advil or Aleve. The next stage would be to do something like physical therapy. The idea is to correct, as I said, the motion of the kneecap, and that includes the muscle balance. So the quadriceps muscles, the muscles above your knee, if they're pulling more towards the outside than the inside, the kneecap will have a tendency to go in that direction and will put excess pressure on the outer part of the kneecap and therefore cause pain. Flexibility is also important in this. We talked about that iliotibial band as that long ligament, long tendon that runs down the side of the leg. There is also an attachment of that up to the kneecap. And if that's too tight, that again will put excess pressure on the outer part of the kneecap. Next level of treatment beyond physical therapy is injections, cortisone injections, and sometimes lubricant injections. These will help to reduce the pain in there, and the specifics of the lubricant injections will obviously help lubricate the joint to work better. And then rarely surgery. This is very uncommon with this kind of condition that it needs surgery. So kneecap instability. This is we call a spectrum of disease. So the kneecap can either come partially out. So if you look at the bottom picture there, the kneecap is not completely out. However, it is sitting off a little to the side. If you can kind of see the contours of the bottom of the kneecap, which is on the top part of that picture, and then the front of the thigh bone, which is on the bottom part of that picture, they don't quite match up. Normally, they're supposed to match up nicely. And then you can also have complete dislocations where the kneecap is completely out of place. This can either occur because of trauma, because of an injury, or in some cases, it actually can occur without an injury. People just have a lot of laxity or looseness in their ligaments, and then their kneecap doesn't track correctly. So for treatment of this, obviously in the emergent setting is to get the kneecap back reduced, and then afterwards brace it, do physical therapy, rehabilitation for it, including rest and ice. And then if you have persistent instability, consider surgery. So runner's knee, obviously, as the name implies, this is a condition that is very common in runners. It includes pain in the lateral or the outer aspect of the knee. As I said, it is generally due to a tight iliotibial band. Treatment for this involves stretching, ice, anti-inflammatories, physical therapy, cortisone injections. And as I said, as with any sort of kneecap disorder, surgery is very rare for this. It involves lengthening that IT band to reduce the pressure and strain on the area. Patella tendonitis, the name of this is also known as jumper's knee, and you get pain just below the kneecap. It's worse with activity, obviously common in people who do a lot of jumping activity, for instance, basketball players or volleyball players, but it can occur in other circumstances as well. And essentially what happens is repeat straining of the tendon causes small tears at the microscopic level. And over time, these small tears add up. Because they're not an immediate injury, the body doesn't have an effective mechanism for repairing it, and therefore it does not repair properly. So the treatment for this, obviously, rest. It's something that's caused by repetitive activity. Resting it is very important. Physical therapy, there is a focus on what we call eccentric strengthening exercises, where basically the muscle up above is lengthening while it's being loaded. And then ice is helpful as well as anti-inflammatories to help with some of the symptoms. Tendon and muscle strains, basically we all know how these happen. The muscle or the tendon gets stretched too far. There's a spectrum of injury. As you can see in that middle picture there, there's a grading system for this. The common sites that this occur are in the quadriceps muscle, the muscle in the front of the knee, the hamstrings, muscle and tendons. Those are in the back of the knee, and then the patella or quadricep tendon, which are in the front of the knee, or either below or above the kneecap. And occasionally you get a partial tearing of the muscle as well. Sometimes the muscle actually peels off the tendon. So it can happen either in the mid-substance, in the middle of the muscle, or it can occur where it attaches onto the tendon, or it can occur in the tendon itself. So treatment for this, again, rest is very important. If things hurt it, don't do it. Stretching to maintain flexibility, particularly in the early stages. We used to basically immobilize these, and what happened was they would heal, but the muscle or the tendon would be very scarred in and very tight, and therefore more vulnerable to repeat injury. So it's important in the early stages, even while it hurts, to stretch it, to try to get it to heal correctly. And then, as I said, we talked about eccentric exercises. That's lengthening of a muscle while loading it. Other things that are useful are icing for the immediate inflammation and swelling associated with the injury. Heat, again, when you're trying to stretch it to get it loosened up. Medications, including anti-inflammatories, and then a gradual return to activity as you go. So tendon ruptures, there's two basic tendons around the knee that rupture, either the quadricep tendon that generally occurs in people over the age of 40, the patella tendon that generally occurs in people under the age of 40. The quadricep tendon, is the one that's above the kneecap. The patellar tendon is the one that's below the kneecap. And in both cases, basically the tendon pulls off the top of the kneecap. And symptoms, obviously, as you might imagine, is that you have weakness in straightening the leg, or you're unable to hold up your leg against gravity. And in most cases for this kind of injury, when it's a complete tear or when it's a near complete tear, this does need to be treated surgically to have the knee function correctly. And then following that, rehabilitation to strengthen the leg. Meniscus tears, as we talked about, the meniscus or the menisci are the cushions of the knee. And the reason they're there is, in addition to providing cushion, they actually round out the top of the shin bone. The top of the shin bone is relatively flat. The bottom of the thigh bone is rounded, so it helps to create the proper contour for that. And the symptoms of a meniscus tear generally are pain with twisting or turning. There's a lot of other things that cause this, but that's a specific, a symptom that's very, very commonly found with meniscus tears. You get kind of a sharp pain with this. It may not hurt at rest. If you're not moving, you may have absolutely no pain. But if you twist or turn the wrong way, you might feel something catching or clicking in the knee, and it usually locates or localizes to one side of the knee. The medial meniscus, so the one on the inner part of the knee, is the most common place to get a tear. They generally will not heal on their own, and they generally do need surgery to be addressed properly. Most of the time, we have to remove the torn part, and this is because the blood supply is not good to that area. If you look at the middle picture there, we kind of show the outer part of the meniscus is where the blood supply is. That's the red zone that's being indicated there. And the remainder of the meniscus is the white zone where there's not good blood supply and therefore not good potential to heal. So any tears in the outer part might be fixable. Any tears in the inner part, which is where 99.9% of them occur, are not fixable. So they just need to be cut out. And this is really the most common reason for knee surgery. So ligament tears, again, there's 4 main ligaments around the knee, and those are there, and we'll go through them individually. So the ACL, or the anterior cruciate ligament, is that, again, that ligament that's kind of in the center of the knee. They're called the cruciate ligaments because cruciate means crossing, and they kind of cross one another, meaning the ACL and the PCL. The injury is commonly a non-contact injury. You just twist or turn wrong, or you plant your leg wrong, and the ligament gets stretched beyond where it wants to, and it ruptures. The function of the ACL is to prevent the shin bone from moving forward relative to the thigh bone and from rotating. And one thing of note, this is becoming much more common with time. When I was younger, we very rarely had these injuries, but I'm seeing it much more nowadays. And it is more common in female athletes than male athletes for reasons we're not entirely sure of. So the treatment, basically in a younger athlete, and frankly, in the weekend warriors, maybe even the older athletes, particularly if you have some residual knee instability from this, is reconstruction of the ligament. It cannot be repaired. The ligament, when it ruptures, basically gets torn apart. So we have to take some kind of graft material and place it where the old ACL was, and the body has to basically grow into that. It acts as a scaffold, and the body grows into that, and it recreates the ligament. After that, there's extensive rehabilitation that's necessary, and it's really anywhere from about 9 months to a year to get back to sports after this. And that's due to the fact that that ligament needs to reconstitute, and that process takes about 9 months to a year. In older people who are non-athletic or basically are not having symptoms of instability from this, this can be treated with physical therapy. However, you must avoid certain activities. Anything involving twisting or turning would not be a good idea. So say, for instance, you wanted to ski. In that case, you would need to have surgery to be able to restore the function of the knee to be able to do that kind of activity. The PCL or PCL tears, again, this is the posterior cruciate ligament. It prevents the backward motion of the shin bone relative to the thigh bone, as you see in the picture, the top picture there with the red arrows. It is much, much less common than ACL injuries. There's about 99 ACL injuries for every 1 PCL injury. Typically, if it's an isolated injury, meaning it's only the PCL that's torn, these don't need surgery, even in complete ruptures. Sometimes they're partial ruptures, but even in a complete rupture, if it's an isolated injury, it may not need surgery. But usually they're part of a more extensive injury. There are other ligaments involved. If that's the case, then it would need to be reconstructed in addition to whatever other ligament injury there is. So MCL tears of the medial collateral ligament. This prevents inward motion of the knee. If you can see there, the red arrow in the top picture, that's the outer part of the knee. And that looks pretty painful, even in the picture, to have your knee bent that way. And it's usually a fall or a hit from the side, or for instance, getting your foot caught and the knee bending in that direction. In most cases, the ligament is stretched. It's not completely torn. In some cases, it does completely tear, obviously. If it's an isolated injury, these generally will heal. They generally do not need surgery. The healing process obviously involves bracing to protect the ligament, resting the area, icing it, anti-inflammatories, as well as physical therapy. As I said, these will typically self-resolve. The reason these can heal, whereas ACL injuries do not heal, is these are actually, the MCL is actually outside of the knee joint proper. It's outside of the capsule of the knee, and therefore there's a proper blood supply to the area and proper healing conditions that this can heal. The LCL, or the lateral collateral ligament, this is the opposite, or the co-pilot of the MCL. This prevents outward motion of the knee. Injuries of this are much less common than MCL injuries. Again, isolated injuries can be treated non-surgically with bracing, physical therapy, anti-inflammatories, and icing. However, it is much more common that an LCL injury occurs in combination with other injuries, and therefore, if there's instability, that surgery is necessary. So bursitis, the bursa is a lubricating membrane. It's a basically small two-cell layer membrane that exists. You have multiple ones of them all around, basically in a joint, your elbows, your shoulders, your hips, your ankles, knees, and these are some of the ones in the knee here. There's the suprapatellar bursa, the prepatellar bursa, which is the one that's in front of the kneecap, and the infrapatellar bursa, which is the one that's below the kneecap. And what happens is that bursa can become inflamed and swollen. This can either be due to injury, i.e. a direct contact injury to the area. It can be due to infection. Sometimes people will get bacteria that seed in there, or if there's a little cut, that can cause it to get infected. Or sometimes overuse. For instance, people who are, let's say, a plumber, or people who do flooring, who work on their knees a lot, the pressure to the area can cause the bursa to swell. And the treatment really is dependent on the cause. If it's an infection, obviously the infection needs to be drained and/or treated with antibiotics. In cases where it's due to either injury or overuse, a lot of times a cortisone injection and aspiration, or taking the fluid out of the bursa, are helpful. So arthritis, what arthritis is in the knee is basically that the cartilage and the meniscus, the linings of the joint, wear out over time. The most common cause of this is what we call osteoarthritis, which is basically just wear and tear. And you can see that picture on the bottom there, where the red arrows, the lower red arrows, where that joint space is almost completely gone. There's no space between the thigh bone and the shin bone there. It's also narrowed on the other side, but not to the same extent. This can be caused by injuries. If you break your bone around the joint, particularly fractures that go into the joint, they disrupt the cartilage surface, and they can lead to arthritis down the line, as well as meniscus injuries. The meniscus is a normal cushion to the knee, and therefore any injury to it or anything that damages that function over time can increase the pressure within the knee and cause arthritis. And then autoimmune conditions. The most common is rheumatoid arthritis. There's also psoriatic arthritis. And these conditions can cause the joint linings, the joint tissue is called the synovium, which is the tissue that produces the fluid within the knee. Those can cause it to be inflamed and therefore destroy or wreck the cartilage within the joint. Diagnosis of arthritis pretty much can be diagnosed on X-ray. It doesn't need any more complex imaging. Labs are occasionally helpful. For instance, if you're questioning whether or not someone has rheumatoid arthritis, labs will be helpful to assist in the diagnosis of that. So just a brief interlude about cartilage health. So cartilage, again, is the lining and cushion on the bones. It helps the bones and the joints to move smoothly. As I said, it produces a fluid that makes it 10 times more slippery than an ice skate on ice when it's healthy. So cartilage doesn't have much blood supply to the actual tissue itself. What happens is when you load your knee, in this case, or any other joint, the cartilage gets loaded and it acts like a sponge. It pushes the waste materials out of the cartilage. And then when you take the pressure off, the fluid gets sucked back in, hopefully the healthy fluid with good and new nutrients in it, and that helps. So therefore, we say for cartilage health, to keep your cartilage healthy, before it gets to the point of being arthritic, moderate weight-bearing exercise is good. So treatment of arthritis in the initial stages, resting it, icing it, medications including Tylenol or anti-inflammatories, use of assisted devices like a cane or a walker or something like that to help reduce the pressure in the area. Again, cortisone injections will reduce inflammation and pain within the joint. And then visco supplementation or joint lubrication, again, will help the joint to move more smoothly and therefore reduce the pain. The goal of all those treatments is basically to reduce the symptoms from the condition they do not change the condition, i.e. the arthritis is still there. They just help maintain the comfort of the joint and hopefully improve someone's function. When those fail, knee replacement is an option. The top picture there shows what we call a total knee replacement, which is what you would do if the entirety of the joint or most of the joint is involved. And then a partial knee replacement, which you see on the bottom picture on the right over there. And that's when you have isolated arthritis. The indications for that are generally rare, and they're generally used in younger people who are sort of too young to get a total knee replacement, but have arthritis, as I said, isolated to one part of the joint. They usually do need to be revised ultimately to a total knee replacement. So some talk about fractures, also known as broken bones. That's the common term for it. There's various bones that can get broken in the knee, the kneecap or the patella. So that the picture on the top there shows a kneecap that has been broken and then fixed together with what you call a figure 8 wire, where it helps to compress the sides so it can heal. The femur or the thigh bone, that's in the bottom picture there, shows a fracture of that. And generally those will require surgery. And then the tibia or the shin bone, the picture in the middle shows that, generally does require surgery. The treatment ultimately, however, depends on what is broken and where it's broken, i.e. the pattern of the fracture and how bad it is. So sometimes it will need surgery, sometimes they don't. It really just depends upon actually looking at the specifics. So I'd like to thank all of you for coming tonight, for listening to this, hopefully providing you with some information on it.